Hi, good morning. We are so excited to see you. Thank you for coming really early. And also that we know we're competing with many other sessions for your time. So we're delighted to have you. And I think with this smaller group, we'd love to also make it a bit more interactive and hear your thoughts. So the topic that we want to get your input on for today is thinking about how we can combine all this effort and energy that's going into pandemic preparedness and see whether we can harness and leverage some of that to also strengthen and improve TB prevention and care and other sort of routine illnesses that are seen not treated as much as an emergency by the health system. So we've got 4 speakers today. I'm going to start by introducing them. So let me start with Phumeza Tisile. So Phumeza is an advocacy officer at TB Proof. If she looks familiar or famous, you are correct. She made the Time 100 Next list a month ago. So Phumeza, we're delighted to have you here. And she's been an incredible TB activist over the years. So welcome, Phumeza. And then we've got Eloise Todd, who's director of the Pandemic Action Network, which actually sprouted out of the COVID-19 pandemic and brought together this coalition of civil society organizations across the globe. She'll tell you a little bit more about the organization, but they're really doing some incredible work to act together as a coalition. So welcome, Eloise. Really, really fortunate to have you here. Our colleague Romina Mariano is a medical doctor from South Africa. Unfortunately, she was not able to travel today, but she has recorded her session via video, so hopefully all of our technology goes really smoothly and she can also present to us remotely. And myself, so I'm Helene Marie van der Westhuizen. I'm vice chair of the board of TB Proof, so Phumeza and I are colleagues. But I'm here today also in my role where I provide support to the Global Health Security Consortium. It's a collaboration between Oxford University, the Tony Blair Institute for Global Change, and the Ellison Institute, so people bringing different types of expertise and thinking together about pandemic preparedness policy. And so this idea, this always-on concept, we want to introduce today, and we want to hear what you think. We want to hear, how can we work with this within the TB space and broadly into the lung health space? So just to say that this piece of work was funded by the Rhodes Trust. We convened, Eloise was there, we convened a policy summit in April, where we also brought together different people to think about, what should we be putting in place for the next pandemic. And this was one of the ideas that we were most excited about that came out of that meeting. So we want to test it with you. And it's centered around building dual-use global health infrastructure. So that means that we're not funding a program that's just pandemic preparedness or just tuberculosis or just influenza, but we're trying to see what kind of health infrastructure can be applied to different settings. And so it tries to bring these 2 circles that's often sort of routine prevention and care and health emergencies. It tries to inch them closer and to say, how do we not do what we did during COVID, where we had either absolute panic and scrambling to put new infrastructure in place, trying to build, surveillance infrastructure at population level, trying to figure out how do we vaccinate adults. We're pretty good at vaccinating children, but how do we vaccinate adults? How do we make that less of a scramble by using some of those strategic pieces of infrastructure in the way that we do routine prevention and care. And so we're going to go through, this is a high-level idea, we're going to go through a few practical examples of what that can look like. This was just a sort of a summary of the meeting, but if we think about pathogen surveillance, so we know GeneXpert, a TB diagnostic technology, was greatly leveraged during the COVID-19 pandemic. Many people used GeneXpert testing to do COVID testing. I think the first question is, if we put in place your pathogen surveillance infrastructure, so GeneXpert machines, for use in case there is a new pandemic, is there any surge capacity that we need to build into that infrastructure to make sure that we don't divert all of our TB resources to a new pandemic and miss out on continuing to provide that routine care? So that's the one question. Secondly, can we be tapping into these large pots of money that have been put in place for pandemic preparedness and use some of that to strengthen what we need for TB? And so this can be for TB pathogen surveillance, so when we look at genomic surveillance, but we've got Gregory here, who's chair of the ETTI, so the NTB Transmission Initiative. Could we tap into some of the pandemic preparedness funding to say, how can we make our health facilities or our shared indoor spaces safer? And we know that TB spreads via the air, COVID spreads via the air, so there's some really good areas of synergy where I think we can present our case aligned to pandemic preparedness. A second example is adult vaccination. So I hope this will be a topic for us to discuss in further depth, but we know that there's a promising TB vaccine on the horizon, but are we ready to deliver it as an adult vaccine at scale? Are our global health systems ready to do that? I worry that we are dismantling a lot of the really good adult vaccination infrastructure that we put in place for COVID. I worry that we're already dismantling it and not saying, are there ways to keep it warm, keep it in use, so that we can also repurpose it for TB? How do we keep it warm? How do we keep it in use? My colleague Romina will elaborate a bit on that, but I think it involves looking at, are there current vaccines that are already approved that we are not using for adults? Things like influenza, things like shingles vaccines, things like the new respiratory syncytial virus vaccine. So all of those, are we able to produce a coherent bundle of adult vaccination infrastructure similar to what we have for kids, and then we can just plug in our new TB vaccine when it arrives? I'm saying when, not if, because we are optimistic. And lastly, I think looking at clinical research infrastructure, we saw during the COVID-19 pandemic how essential that is for the pandemic response. And we saw communities and areas that had clinical research infrastructure capabilities being able to respond faster, being able to get sort of access for their populations to novel vaccines faster. So how do we build equity into the way that clinical research infrastructure is distributed globally, and see that again, not just as essential for research, but can we fund it as an essential component of being prepared and ready for a new pandemic? So really excited to continue the conversation. If you wanted to dip into some of these topics in more detail, so all of the sessions of our Pandemic Policy Summit is on YouTube. So say, for example, you've got a special interest in pathogen surveillance. There's a section on that to say, how do we think through always-on pathogen surveillance? But I'm excited that we've got this group together today, and we're going to save enough time for Q&A. So Eloise, you're up next. I'm going to open up your presentation here.
Thank you so much, Helen Marie, and thank you all for being here today. And it's a great honour to share the panel with my fellow panellists. So just to introduce you to Pandemic Action Network, which I'm the executive director of, our vision that we set up in early 2020, as Helen Marie said, we came in this kind of the early months of the COVID crisis, very concerned about the lack of civil society voice. And from the perspective I was sitting in, I'm originally British, now Belgian too, sitting in Brussels, watching different European governments have very different responses to the crisis, and thinking this can't be good. The leaders are making life and death decisions here. We're going to end up exporting this problem to countries with more fragile infrastructure, and there's not quite the sense of urgency about the international dimension that there should be. So we developed this vision where we want to see every country prepared to prevent and stop outbreaks from becoming deadly and costly pandemics. We say that outbreaks are inevitable, at least some, although we can reduce the likelihood, but pandemics are essentially a political choice. So how do we do that? We believe in the power of partnership. No one organization can nail this alone. So we've over time built up to 350 plus organizations that are part of this network approach. We are around in 4 continents. So Latin America is a bit of a gap for us, but otherwise we have a thriving community in Africa, and we're actually about to set up a legal entity in Africa so that we're not the typical northern-led organization, that we work in partnership as equal partners and become a lot more southern-led in our approach. How do we operate? What does it mean to try and get governments listening? We believe in advocacy, so we try to develop policy tools from research, from scientific work, and turn it into policy recommendations. And as I say, working in partnership to make sure we can get the expertise of all of our different types of organizations. So what have been the challenges for us? Even when in those early days of 2022, when Russia invaded Ukraine, I would say that COVID fell off the news cycle altogether. Even before that, it was getting harder and harder to get government attention to sort of sustain on these issues. And there's a famous saying in the pandemic world of this cycle of panic and neglect, that after, as we saw with Ebola in 2014, after that was over, there was this cycle of neglect that kicked in, and lots of kind of good thoughts about let's make sure this never happens again. But when the spotlight goes, the attention drops off. I would argue that during COVID, because of the strangeness of the situation, the psychological, people don't really want to think about it, don't really want to go back there mentally. So we were already fighting with that during the crisis. We didn't see the kind of global coordination that we really needed to see. It took a very long time for anybody to convene at the international level. In the end, that was President Biden, and not until 2021. And then the persistent inequities are really at the heart of what we try to work on. We try to make sure that there are different approaches so that we don't have this absolutely big structural inequity. These are some of the challenges, and it's also the reason I lay these out is because these challenges are some of the reasons why, when I heard this articulation and we got to understand this articulation of the always-on agenda, why we're so excited about it. So what can the always-on agenda bring? In our experience of talking to policymakers and government leaders, you can make the case for prevention. The ROI is really clear. It makes perfect sense. It doesn't cost much compared to what you can save. Despite the logic of it, it's really hard to make a preventive case for anything. And so this kind of light bulb moment of hearing colleagues like Helen Marie and her colleagues from different organizations saying the always-on agenda is about making the immediate case for action, not just the contingent case. It's really what we talk about as good development and good policy practice anyway, to get rid of silos, to make sure that everything we do leaves a structural legacy for change. But it gives a framework, it gives a way of thinking, and as we'll hear from Romina, it also has some practical ways of doing that at a more technical level through various different pillars of the work. So we really think that this always-on approach, it says to governments, you're not just kind of saving for a rainy day. You're not doing this in order to prevent pandemics just in case it happens. By the way, we know it will happen. It's just a question of where and when. And of course, we are fighting existing pandemics of different varieties, which again kind of go up and down the agenda depending on what's in the news cycle. So all of this is about saying, what are the interventions we can make that are a win-win, that help us keep the system going, build up fragile health systems, build trust in communities, get more community healthcare workers out there, get adult vaccinations rolling, start thinking about the future kind of interventions that we're going to need in a health system, and already organise for that now. And by the way, it just so happens that all of those things will leave us much better prepared if a pandemic threat occurs, and indeed if an outbreak or threat turns into an epidemic or pandemic. So how are we working to integrate always on in our pandemic preparedness and prevention response agenda? We've already got over 100 organizations signed up to the principle within a kind of body of recommendations that we've had that went into and came out of the UN General Assembly this year. We included the Always On agenda explicitly there, and this is a way of sensitizing partners to this. It's not yet, this is a new concept for our partners, so we're kind of introducing it gradually, but also making sure that we make the connections between, for example, the climate and health agendas, which is a big agenda now for many countries, including those in Africa. And so we were delighted when Kenya's President William Ruto said in June, actually in Paris, that health is the human face of climate change. So there's been a lot of focus on loss and damage, adaptation, all important issues, but the human iteration of some of that is about building resilient health systems for the future. Yes, to do with climate change, but also climate change brings an increasing amount of pandemic threats. So we're trying to connect the dots on that and bring the Always On agenda into some of these international conversations. So I'll just leave it there so we can focus on conversation, but happy to talk more about our work, and the importance of working together is simply vital. We do get the difference between sending interventions that are backed by one or two organizations or saying actually 100 organizations from 4 continents have signed up to this, you really need to talk to us. It makes a huge difference to work together. And so I'd encourage all of you to talk to me later about how to get involved. Thank you so much.
Fantastic. Thank you so much, Eloise. I'm now going to click on Romina's presentation. Let's hope.
To speak here today, and apologies for not being able to join you in person, but you are in the best of hands with the other excellent panelists and our esteemed chair. Helena Marie has already set the scene for the always-on approach for which our group, the Global Health Security Consortium, is advocating. One priority area that our group has been working on, particularly under the always-on umbrella, is to reorient health systems towards prevention by building the case for a coordinated program for adult vaccination and disease prevention that we have called One Shot. And that is what I will be elaborating on today. I have no disclosures. Our always-on approach to adult vaccination aligns with the 4th strategic priority of the WHO's Immunization Agenda of 2030, life course integration, where eligible individuals would have access to life-saving products from childhood into adolescence and into adulthood. Of course, robustly designed to avoid drawing on any of the resources for childhood vaccination, but instead to provide continuity into the later stages of life. As part of a revolution that began before COVID-19 emerged, vaccine technology has been advancing at a speed with new programmable platforms, including RNA and viral vectors, making it easier to create new vaccines. Meanwhile, the ongoing evolution of adjuvants and lipid nanoparticles means the next generation of products will soon be available to tackle many of the world's pathogens and chronic diseases. Together, these advances will enable us to prevent many high-burden diseases. We also know that healthier individuals fare better in the face of a pandemic and are likely to do so in future. Furthermore, the additional benefits of vaccination, such as cardiovascular protection with regular flu vaccines, or the suggestion that the shingles vaccine may promote better brain health, are becoming more evident with increased use. Adult vaccine campaigns have traditionally been siloed into individual diseases, but we need to think more broadly. What you can see on this slide is a diagram from a paper that we published, where we've outlined some of the potential candidates for an adult vaccination program, with the size of the bubble indicating the burden of disease globally. These include new and existing vaccines for flu, RSV, pneumococcus, malaria, and of course, tuberculosis, as well as long-acting injectables to prevent heart disease through better control of cholesterol and blood pressure, and also pre-exposure prophylaxis for HIV. Emerging technologies and established vaccines are an integral part of the infrastructure for the one-shot program. But how do we get these to people? Well, during the pandemic, amazing efforts were made to stand up tools to manufacture and deploy vaccines at speed, and to identify and track individuals, especially those most at risk, and then being able to link these data sets to surveillance and hospitalization data enabled data-driven policy decisions to be made in a number of places. However, the COVID-19 vaccine rollout also exposed inequities in the geographical distribution of vaccination. By leveraging and expanding these efforts into a global program, we can address these diseases, which are all areas of public health concern. A program that brings this all together would seek to make use of these products routinely, especially within primary care. Supported by the right digital health infrastructure, health systems would ensure that eligible cohorts are identified, contacted, and made aware of what products are available to them. This deployment infrastructure could then pivot in the face of a new pandemic, thus avoiding the start-stop approach. And finally, with a surge in manufacturing initiatives, a globally distributed, technologically diversified global manufacturing network would essentially start with a better understanding of supply and demand. Demand would be generated by knowledge, awareness, availability of new products, and better data collection. So how do we make this all work? Well, what we need is a global oversight model with scientific advisory groups that will issue recommendations for an intervention schedule for adults, which would be adapted to different regions based on the outcomes of clinical trials and real-world evidence studies. We need timely, consistent, and representative data that can be used to track regional burden of disease and enable efficient decisions and accurate cost-benefit analyses. And finally, to adopt a bundle approach to adult vaccinations. Bundles would include combined vaccines, such as the exciting developments in combining flu, COVID, and even RSV literally into one shot. But more importantly, combined advocacy and deployment infrastructure that empower adults to take control of their health. Bundles would consider demographics, regional burden of disease, and other individual risk factors, and enable us to view adult vaccination in a systematic way. As you can see on the right, a figure from that same paper that we published shows how you would be able to account for the needs of particular groups, such as pregnant women, the elderly, or healthcare workers. And so where do we start? The Global Health Security Consortium is working with partners to design a series of pilots that will help us explore the implementation, acceptability, feasibility, and economic analysis of this always-on approach to adult vaccination. We are beginning by piloting the rollout of a respiratory bundle, including COVID boosters, flu, pneumococcal, and later adding in RSV, for the elderly and healthcare workers, working with institutions in Rwanda and Scotland. We aim to scale this up to include other countries and truly build momentum for a global program to ultimately secure trusted and sustained interaction with populations and their healthcare systems in a proactive way. We hope you will join us on this journey. Thank you.
Apologies. Up next, we've got Promesa Tasila, and she's going to speak about shared learning around advocacy campaigns between TB and COVID.
Yes, thank you, Helen, Mary. So I think we should ask ourselves, like, what should COVID-19 learn from TB? So for instance, before masks were a thing, like before masks were cool, that everyone was wearing masks, TB Proof has this campaign called the Unmask Stigma, whereby we were trying to make mask wearing as normal as possible. Like for instance, when I had TB, I'm actually an ex-TB survivor, it was really a struggle for me to wear the mask because of judging. You know, people will judge without even saying anything. So we thought now we should start on this called the Animal Stigma, whereby around World TB Day, because that's where it all, like, like the tired, like the World TB Day, like the focus on TB is on March. So every time on March, we'll get like students and everyone, like general public, to wear the mask to show that it's fine to wear the mask and that there's no shame in wearing the mask. And then when COVID-19 hit, and now there was this idea that this is also an infectious disease. Of course, people had different insight of what COVID-19 is. But then we knew, doctors obviously knew that it is an infectious disease and it might help for everyone now to wear the mask. So we had this campaign called Mask for All. And I remember especially Helen Mary had these webinars with the WHO where they were talking about evidence that is, wearing the mask could actually help stop the spread of COVID-19. And I think it was adopted lately after a couple of weeks. And then we had the president of South Africa on TB wearing the mask. And now everyone was wearing the mask. It was a cool thing. We didn't have to fight for TB patients and just people in general to wear the mask. So it was a cool thing. But then after the COVID-19, now we're back to square one. Now patients feeling shame of wearing the mask. So yeah, there's lots to work when it comes to TB. But then we can learn from COVID-19 that it's fine to wear the mask. We were wearing the mask to protect the other person. You already have whatever disease you might think you have, but now you are wearing the mask to protect the other person. So that is one. What can COVID-19, what could TB can learn from COVID-19 and vice versa. So another thing that we do, especially at TB Proof, is we have this collaboration with community healthcare workers. They're also called CHWs, and there's a closer word called Onompino, which actually means the helpers, like they help. He works very close with them, that's why I'm looking at him. So anyway, we noticed that they are very important people in our communities because patients really trust them. So, and also our CHWs provide TB care. And also when it came to COVID-19, they were essential to the response, but similar challenge like lack of PPE at the time because, there were lack of mask. So people were advised to make their own mask, cloth mask especially. So also there was also an inadequate, they were also sort of like not really trained on how to take care or rather how to pass on the message when it comes to mask wearing or the PPE. So TB Proof, we used our advocacy platforms to highlight this as an urgent challenge because we needed them as part of the urgent response. So another thing is what TB can learn from COVID-19 now. So there is accountability for policy implementation. So for one, the general public, we're not really we're interested, involved in holding political leaders accountable for implementing essential COVID-19. As I've mentioned that we had these webinars that were happening, also with the WHO and also within smaller South African, so that people can be aware of this campaign called the Mask for All. So people engage with essential details like how long to isolate when it comes to COVID-19 or also when it comes to TB, and how to make sure that people feel safe. Although we have not seen the same level of agent for TB policies, it's very different from TB policies. And also there are areas where we think that some things might have been missed. Like for instance, there was this policy that said that for testing for TB, you should go to the healthcare facility after 2 weeks. And then we're not sure why the wait. Why should you wait to call for 2 weeks and then that is where you go test? It didn't make sense. But then for COVID-19, if you don't feel well, there are no waiting period, you just go to the clinic. So we had tried to change the policy and also hold people accountable that there should also be no waiting period for TB. People, if you don't feel well, just go get screened or get tested for TB. And yeah, so that is what COVID-19 should learn when it comes to TB. So I'm not sure if I still have time. Helen Mary? Okay, 2 more minutes. So, yes, so as civil society, which is TB Proof, we saw the difference that adequate funding can make for the development of new tools, such as diagnostics and vaccines. And also we highlighted how inadequate that we have for TB is, but it also demonstrated the importance of building access into the very initial stages of the design of the new tools that can be available. So in conclusion, COVID-19 highlighted the worsened, which is the inequalities when it comes to infectious diseases, and how for one it started at a rich country and then everyone had to stop doing what they were doing. But then for TB, a leading cause of death, and people barely know nothing about it, and nothing is being really done for it, especially when it comes to vaccine. We only have one vaccine that is over 100 years old, and it's not even effective for the disease. But then for COVID-19, pharma companies were fighting on making the best vaccine available. It didn't make sense to people who were actually affected by TB as to why, pharma companies can make a vaccine in less than a year, but for TB we have this vaccine that is not even effective for the kids, like the BCG vaccine. But of course that is another story, but I think it's very relevant for this story. So we saw the inequalities and how diseases are treated, and if it affects like rich countries and poor countries, although it is still an infectious disease like TB, COVID-19, I think we should learn. I mean, I've talked to multiple conferences of why TB is not being given the attention that it deserves, because it is the leading cause of death of infectious diseases, especially in South Africa. So advocacy should focus on what we can put in place now to better respond to the TB crisis, which I just mentioned now, and for the future pandemics that might occur. Thank you.
That's really well said. Thank you, Pumeza. I would love to now ask from you we've thrown out lots of ideas. There was things about adult vaccination infrastructure, tapping into pandemic preparedness funding. Pumeza made some really good points about health equity. Eloise's points about the importance of creating networks and acting together, civil society. What resonated with you? What would you like these two experts with their black belts in advocacy, what would you like to ask them? I'm going to open up, so if you want to raise your hand.
Thank you very much. It's a nice presentation. But what I like about your statement, I've been sick and tired of when we do interview, what did you learn from COVID? COVID learned from us. Covering your mouth when you cough, it comes from TB. Wearing a mask has come from TB. The 14 days isolation is a 14 days of dots in our clinics. Why would not even ourselves, when someone asks you this question, you said, no, I didn't learn nothing from COVID. These ideas that COVID used, it's our ideas from TB community. I'm right, I'm talking lies here. Two, the vaccination, I don't know what can we do as an advocacy, what can we do? We must learn from HIV community. Today we're talking about them drinking one pill, dolutegravir, that is a combination. Why we can't also having now, also fighting and trying our government cry out to say we need a prevention, because they say prevention is better. Today they are enrolling about PrEP. Where is 3HP? So before even we start from the vaccine itself, just a minor thing, a tablet that can be, is there as an age, but is taken by eligible people 5 years to and old people. Why we can't fight for that to everyone to be protected? Because you are breathing, no matter you are 40 or 60 or 5 years, you are still breathing. And this what we're talking about is an infectious disease that is affecting lungs. So I don't know what can I ask you guys, where can we start with this network of starting demanding these essential things that we think we need? Because in COVID-19, when you have a COVID-19, they close the whole firm when someone is sick. Why we can't do the same when we have one employee having TB, the firm must be closed down and everybody can go and test it. Thank you very much.
So much for some really great presentations. So I was actually part of a program, it was actually Unitate funded, and we were supporting 5 different countries, South Africa, Ghana, Mozambique, Ethiopia, and Philippines. And it was called Impact for COVID. So we're actually wrapping up now. So one of the reasons why I wanted to come here is because we're also working on our own pandemic preparedness, just trying to figure out what that means. But I think what was really interesting about your presentation, Eloise, was the networking and the partnerships, because I felt like we were kind of working in silos. Everybody was kind of competing for this little piece of pie, This, COVID was just like everybody was really competing for the space, but there wasn't enough cohesion in terms of how we worked. As you're saying, you're working on pandemic preparedness and we're doing it on this side. So I think it would be great for us maybe to just get more, to just liaise further with you after this. And then just in terms of Pumeza's presentation, I think I just felt exactly how you feel. Partners came in, we were creating tools, these paper-based tools, and burdening the facilities with these things that they had to now recreate, where they added COVID components, COVID screening components. But right now we don't really know what's going to happen to those, because what we found was that the health facilities didn't necessarily take them on, because these were just a really rather uncoordinated effort by various partners. Everybody was creating their own tools, their own screening tools, but the interest is gone. Nobody's really interested. There's COVID fatigue. People have moved on to other things, but now we're left with these white elephant tools that nobody's using. So I think that's another lesson that we had to learn from this whole thing: coordinated approach, working in partnerships. I don't know, I guess hindsight is we learn from hindsight. I mean, at the time, everybody was just rushing to manage this pandemic. Thank you.
Hi, good morning. Thank you guys all for being here. And I totally agree with your point. I think one of the challenges that we faced over, quite a few years, but specifically highlighted recently, is program integration, right, between TB, HIV, things like this. So I think that's a key to that, as you say, partnerships and unlocking some of that power. But I have a question for Eloise around, what do you think is the nearest kind of use case for all of this activity around preparedness, right? So today, people are doing a lot of activities in country, supported by the WHO. There's tons of guidance coming out. They're doing DNO. How do we keep it warm? Like, what is the kind of target or disease state that could keep this activity warm? I don't think, TB is not necessarily hasn't been a historical use case. Maybe we could position it to be. But when you think about surveillance and connectivity and collaboration, cross-sectoral, all these things, what is the disease state that we should use to keep this network warm?
Fantastic. I think let's start there, and we'll open up for further questions. I'm happy to share some thoughts on that last question, then I'll hand over. So I think, and this is conversations between myself and Rumina and Eloise, is I think we won't find one illness or disease burden that will keep our pandemic infrastructure warm. I think we will need to look at routine care as a whole and say, do we create sort of a respiratory bundle of adult vaccines that we know will probably be more cost effective to deliver if you have a bundle instead of just having a flu program or RSV program, if you can share the costs of the vaccinators a lot together. But I think the really interesting idea from Rumina's presentation was, can we add in the NCDs? So if you creating vaccination infrastructure, is there really a big difference between giving someone a COVID vaccination and giving them an anti-cholesterol injection? Maybe not. Maybe that's an example of another way where we can keep infrastructure warm by using what we will need in the future for parts of our routine care. But that's quite a radical idea. I think we will need to get a little bit of enthusiasm around it. Eloise, can I hand over? Do you want to use that one? Just also speak about sort of the importance of partnerships, program integration.
Yeah. Brilliant question and brilliant comments from everyone. Just on that last point, my mind goes to several different kind of layers that we need to sort out, if you like, when it gets to implementation and preparedness, and the kind of the issue we have in both practical application of these things and in advocacy is that there are a genuine need, obviously, to highlight the specifics that certain diseases need, whether it's TB, whether it's COVID. And yet we have set ourselves up for false competition between all of these things, and it means that the systemic advocacy, the systemic need, has sort of shunted down the agenda, the finance agenda, the political agenda, the campaign agenda for a long, long time. That has kind of practical ramifications when it comes to how are partners asking low and middle income countries to organise their health systems. What are the plans that they have to put in place? Is there a plan for TB? Is there a plan for the whole system? Is there a plan for pandemic preparedness? You know, there's a new pandemic fund that asks for one plan, the global fund asks for another. So some of this is kind of boring bureaucracy, but it's so important because it's about how we pull together all the different strands of slight dysfunction, get one systemic approach, but still have the experts and the advocates that are saying, that's great, let's work together. By the way, you must absolutely remember this on TB, on HIV, on COVID. So it's this, we've oversteered towards the individual disease approach, I would say, with good intention, but the practical application of that hasn't necessarily led to a sort of natural recalibration of where all the finance needs to be. And if I may just take our first speaker's point, absolutely right. You know, the world, it must be really frustrating to be a campaigner on issues that have on lung health that gone far beyond and far before COVID, when all of a sudden the world wakes up and it seems that COVID invented everything. So I think your point is really important, and how we message and acknowledge and pull together in these networks is so important. And then just to the point about coordination during COVID, I think, you know, I've worked in these issues, on these issues for 25 years. I'm not a scientist, I'm not an expert, I'm a kind of, the only thing I'm expert in is in corralling people, advocacy, campaigns, that kind of thing. But it's really important to know what you don't know. And at the beginning we were like, everybody's flailing because nobody's really got a handle on COVID. So let's provide the forum where we can bring that together. So there's always better ways to do this, but I'm absolutely passionate about the fact that networked advocacy and networked approaches, where it's not about your own organisation, it's about saying, hey, they've done this before, let's lift it up and look at what they're doing, is absolutely the future. P.S. There's also a funding issue there, because one of the reasons people compete is there's less and less funding for that work as well. So important to pull together and make sure we're making the case. Sorry, that was a bit long.
No, I think really excellent points. Pumezo, do you also want to comment on Goodman's question, how we can get more innovation going for TB similar to what we saw for COVID?
I think what TB needs is, we need to hold our governments accountable for things. Like, for instance, as she mentioned, that there are tools that were used for COVID-19, and then now they are just there. So we need to have this. It's really hard because we've been doing it for quite a while, but we really need to hold our governments accountable for what needs to be done. And also when it comes to TB, you know, the inequalities, as I mentioned, that if a disease, you know, affects certain people, then it becomes a problem. But then if it affects certain people, then some people say that is not my problem. And it's something that we need to deal with. That's why in TB we try to have, you know, celebrities to be part of the talk. I mean, at some point, Stop TB Partnership tried to get like that footballer who's famous, a Spanish footballer, because she also had TB when she was a child. And we tried to bring in that Desmond Tutu also was supporting of TB, also had the TB, and Nelson Mandela, to make people aware that this is a problem. Anyone can get TB because it's in the air. But without us, a civil society organization, and also just people who are actually affected by TB, and actually speaking like we did with HIV. Yes, we learned a lot from HIV. And as we said, yes, we did learn something from COVID-19, as COVID-19 learned something from us. But yeah, you know, we have different feelings about that. But because it's an infectious disease, just as TB, I think we did, especially when it comes to mask wearing, which was very important. And I see some people in this room are still wearing masks, because now, if it was normal, we didn't know anything about COVID, then no one would be wearing a mask in these events or in a plane or anywhere, because, you know, we did learn something from COVID, that when you're feeling sick, you should start wearing your mask. Doesn't matter if, you know, when you start coughing. Yes, we did learn from coughing on the airway, but it's not really, people don't really do that, but it's much better when you wear the mask. So I can talk go on and go on, but I saw we are over time, but I just wanted to highlight that we need to make our governments accountable, and we need to know, like, the tools that are not, maybe we can use them for TV, I don't know, maybe, yeah, maybe.
Yeah.
Thank you. I think the topic is of global importance, actually. The pandemic we had, actually with lower mortality, was devastating for the planet. If the mortality will be for next pandemic like 10, 20%, it will be just disaster. And there are lots of things in common between TB control and pandemic preparedness. The next pandemic for sure will be airborne again. So the things we do to prevent TB, airborne transmission of any respiratory infection, again, including the next virus, next bug. It's the same measures we do to prevent TB transmission in healthcare setting and community settings, congregate settings, at home, and so on. So there are lots of synergies between TB control and pandemic preparedness. And I think this is the leverage to improve TB control and stay prepared for countries' health systems and so on. This is the ETTI and TB Transmission Initiative, Stop TB Partnership Working Group, which actually eager to be helpful for pandemic preparedness and for countries and so on. So to the list of your partners, you could include the group of the professionals involved. And it's not only about masking, about improving ventilation in public spaces, it's about triaging, it's about rapid testing, infectiousness assessment, and so on. Many issues are common for TB and COVID and next bug, which will be. So we have to work together. Thank you.
Thank you. So I realize we're at the end of our time, but I just want to say I think this is some really interesting new thinking coming from this group. I think we used to coming to a TB conference and only speaking about TB, but I think we're in agreement that there are some really important opportunities here to see how we can find that bridge between the emergency that we know and trying to communicate to the global world that we need to pay more attention to, but also preparing for future devastating pandemics. So thank you. We will be around. We'd love to hear if you want to join the Pandemic Action Network or get in touch with further work. Maybe if you have ideas around how to put some of this pilots into practice, come and talk to us. It's been lovely to spend this morning with you. Thank you for joining us.